there is a field study on the level of awareness on diabetes mellitus among the people at Hatigara village of Kumilla. A case study, and this study was done by myself, Dr. Deepak Chandra Das, and my colleague, Mr. Rahani Samai. We acknowledge our gratitude and sincere appreciation to
Thank you, sir.
Okay. What is diabetes mellitus? The rise of blood glucose level to the individual due to lack of insulin or insulin production is called diabetes mellitus. And there are mainly 4 types of diabetes mellitus: type 1 diabetes mellitus, type 2 diabetes mellitus, type gestational diabetes mellitus, and diabetes due to other causes. Introduction. Diabetes mellitus is an increasingly important medical and public health issues because it is common increases the risk of cardiovascular and kidney disease. Bangladesh has been experiencing a high rise of diabetes mellitus patients during the last 3 decades. A study was found that during from the 1994 to 2018, there is increased rise of diabetes patients from 4.5% to 35% in our country. High incidence of metabolic syndrome and lifestyle related factors like obesity, then high salt intake and less physical activities are the major key factors of the diabetes mellitus. Then, general objectives of our study: to assess the level of awareness about the diabetes mellitus among the rural people. And specific objectives is to find out the level of awareness of diabetes mellitus among the respondents of the village, to assess the risk factors as well as the complications, and to know the status of medication and make recommendation based on the findings. The scope of the study: assessment of the age, education, and socio-economic status of the people of the community thinking about the diabetes mellitus, and the concepts about the signs and symptoms of the diabetes mellitus, finding out the effective way to prevent any complications, and finding out the effective way to reduce the adverse effects of the diabetes mellitus. Limitations of the study: this study was conducted in a confined geographic area, that is called Hatigara of Kumilla, and sample size was very simple. We could take only 30 people, and the study was within a short span of time. The variables used in the study: we have age of the respondents, sex of the respondents, occupations, educational qualification, and knowledge about any complications such as hypertension or any other cardiovascular disease. Lifestyle. Then we have also taken account the lifestyle of the respondents. Methodology: name of the study is cross-sectional study, and the study site was the Hatigara, Kumilla. The duration of the study 1 day. Sample size: the sample size is only 30. Then sample collection from simple random sampling. Sources of data is primary data. The material we used is structured questionnaire and scheduled interview. Data collection procedure is through interview schedule. Then data processing and analysis was then tabulated and analyzed. Limitation of the study was that study was done within a confined geographic area. And those are the pictures we have taken during the data collection. Then findings and analysis, and we have seen that the sex distribution of the respondents, near about 57% of the people was male and 43% was female. The age of the respondents, we have taken account near about the people of middle-aged people. The middle-aged people are near 30 to 60 years old, and we have taken only 4 people of legal age. Occupation of the respondents: maximum were the businessmen and some of the service holder and farmers, and we have taken some of the data of housewife. Family history of diabetes mellitus: only 5 people have the family history of diabetes mellitus, but there was no, the 25 people was not having the history of diabetes mellitus. The specters of diabetes mellitus, and we have collected data that there were 6 people have central obesity, 12 had hypertension, 11 were taking the fatty foods. Central lifestyle was only 1, as there is we have taken data from the village, so maximum people were not in the sedentary lifestyle, and 5 people were smoking, smoker, and inheritance only 1%. Treatment of the diabetes mellitus. Only 20 people was taking the insulin or oral, only 35, 20 people was taking oral anti-diabetic drugs, and 15 people were taking insulin. Near about 60% of the people have idea about the diabetes mellitus, and 40% don't have any idea. Complications of the diabetes mellitus. There are many complications such as stroke, kidney problem, heart problem, eye complications, and neurological problem. And 5% was having the stroke history, and one people was having the kidney-related disease. Then 8 people were having the drugs of cardiovascular disease, and 5 people were having the eye complication. Knowledge about prevention of diabetes mellitus. 12 people were having the idea of the diabetes mellitus, but 18 people don't have any idea of diabetes mellitus. Relation of diabetes mellitus with pregnancy. 83% of the people don't have any idea about the gestational diabetes mellitus, but 17% of the people have the idea of the diabetes mellitus, gestational diabetes mellitus. Idea about the relation of age with diabetes mellitus. We had respondents about 28 people, and who are the elderly age, and only 2 respondents was in between the 20 to 40 years old. Idea about the comorbidity, hypertension, heart disease, and kidney disease. Only 7% people have the idea of the complications, and 93% doesn't have any idea. With this, I conclude here. I would like to request Mr. Haris Bhai to extend his next portion. Thank you.
Assalamu alaikum. Thank you, my dear colleague, Mr. Prakash. Thank you, sir, for giving me the opportunity to present my field study in front of you. The name of my field study is the level of awareness about diabetes mellitus among the people at Hatigara village of Sumila. Here in this picture, we see that idea about comorbidity, HDN, hair disease, kidney disease, others. And the distribution, 93%. We see that in this data, the pie chart, that 93% people respondent have no idea about the disease. They can bear by the diabetes, and 70% have idea. Only 70% have idea. In this first pie chart, we see that we observe that yearly checkup by the patient, there are 30% respondent only checkup yearly, 70% don't do any checkup. And the next pie chart, we see that patient taking medication regularly, there are 40% only taking medication regularly, but 60% don't have. In this first pie chart, we see that one patient having other methods rather medications, that 40% have don't take other medication, but 60% take other medications. And the next pie chart, we see that 3.16, that patient following doctor advice, 30% only follow the doctor advice, but 70% don't. we survey that monthly income of the respondents. Monthly income there are we see that in this chart that number of participants 2000 and 20,000 and 30,000 there are middle means maximum people are middle age. Number of and the percentage is 33%. Monthly health expenditure of the respondents we survey 30 respondents and we see that there are monthly income range 3,000 to 4,000 are 12 people and there are 40%. In this conclusion, the implication of our study are potentially used in the way that awareness to some extent is present among the population about diabetes mellitus, but there is some misconception and misperception also prevailing in this industry. People know little about risk factors and complications of diabetes mellitus. In this regard, people should have proper health education about the risk factors and complications of diabetes mellitus. Emphasize should be given over screening procedure to detect the diabetic and the pre-diabetic population, which will have a big impact on reducing the total burden of stroke, eye disease, kidney disease and ischemic heart disease, which are the already leading causes of adult mortality and morbidity in the country. At the last of our survey, we recommend some point that large scale of studies are needed to determine the actual status of awareness about diabetes mellitus among the rural people, to enhance health education program containing different ideas about diabetes mellitus. And third is a proper utilization of media such as radio, television, internet, newspaper, etc. to provide updated and fruitful information about diabetes mellitus to the people. A resident medical officer, that means RMO, and medical officer of disease control should get TOT, that means training of trainers, training about diabetes mellitus, which may be distributed over the medical assistants working in different community clinics. And that is a survey we do in Hatigara village. And it's the questionnaire. We ask the respondents. Thank you.
So we can give them a big hand. Actually now question and answer. So please, if you have any question, please raise your question, please.
Thank you. Very nice presentation. My question is, what should be the lifestyle of a diabetic patient? And the additional question is, I know your home is in Puranhak area, and we know that lots of people here are used to take heavy meal like biryani and other things. And do your family maintain the healthy lifestyle? And you are clear.
At first, I answer your second question. That is, my family also taking heavy meal. And there is biryani, kachi biryani, lachi. We don't maintain any doctor advice. But we should maintain.
Honey can reduce the impact of the fatty food. Honey. Okay, please continue.
But we should maintain doctor advice, take control of this food. And I talk about your first question. The diabetes patient should have to leave at first. If they are smoker, they leave smoking. And taking a small amount of food at regular space of time. Regular physical exercise they have to maintain. Avoid high rich carbohydrate food. And also drink fresh water and taking medication regularly and follow the doctor checkup. That's all. Thank you.
One more question, please. Only one.
Thanks for your brilliant presentation. I asked Dr. Biplab a question. What are the complications of diabetes mellitus?
Hello. Thank you, Dr. Ujjwal, for your nice question. Actually, there are several complications of diabetes mellitus, and mainly we can said as that is microvascular completion and macrovascular completion. Microvascular completion results from the small vessels. So the diabetic retinopathy, diabetic nephropathy, diabetic neuropathy are the mainly microvascular complications, and macrovascular means macro means big vessels. So macrovascular means then the cerebrovascular disease such as stroke, then cardiovascular disease such as heart disease, MI, myocardial infarction or any heart attack, then peripheral vascular disease. Thank you.
Okay, please.
Thank you, presenter, for your nice presentation. I have the question for Dr. Biplov. What are the investigations done during checkup?
Thank you, Dr. Flora. In regular follow-up or regular checkup, we have done several types of investigation, such as blood glucose tolerance test, then or fasting blood glucose or 2 hours after breakfast, then fasting lipid profile, then HbA1c. Thank you.
HBO.
Okay, thank you. Anyone conclude? Is there any question?
Is there any question?
No, no question. Okay, thank you very much. We can conclude the presentation chapter. Please take your seat. Now my turn to say a few words about the presentation. Actually, first of all, I would like to thank both the presenter for their enthusiasm in terms of preparing the report, collecting data, preparing questionnaire, and preparing the report, PowerPoint slide, everything. And also they have tried to do presentation by their own level. So in that point of view, it was a good presentation. So I must appreciate for their presentation. Now I want to take the privilege to say some discrepancy of the presentation or report. So there are some limitation or deficiency of the presentation and also the report, more or less the same. Actually, most of them have given by their own experience and own perception, because they are the doctor, na? They have some idea, they have knowledge, but the rural people do not have that type of knowledge. What is the relationship with diabetes and other complicated disease? It is not the matter of the general people. So you have to build up your conclusion based on your findings. What are the findings? Only data presentation. No discussion is there. If you write the discussion, then this is the result, why it happens. So it give discussion. So if you give the discussion, then you have to have substantial review of literature. You cannot tell anything from your own mind. You have to tell everything by the reference. Understand? Without reference you cannot say. Based on in research, there is no scope to say by your perception. You have to say anything from your research background, research findings, research result, discussion, by reference. And the most important limitation is that you mentioned the cross-sectional study. Then you have to explain what is cross-sectional study, what is non-cross-sectional study. You have to explain. You told that this is a cross-sectional study. What do you mean by cross-sectional study? And what is non-cross-sectional study? Why you are going for cross-sectional? Why not non-cross-sectional? What is the limitation? You have to mention. Then you put limitation after objective. No, limitation always methodology. After methodology, then you write the limitation. Setting of the point is very, very important. You mentioned random sampling. You did not carry out random sampling. You just use the composite sampling. Is not it? So why you write it, the random sampling? Do you know what is random sampling? I have taken a class on sampling technique, population sampling. I have I have informed you through this session, but almost all of you did not take cognizance, take your cognizance. So that is very frustrating to me. Then take how number of people or percentage of people taking medication. So you mentioned 20% to 20 people out of 30, 20 insulin, 15 hormone, 10. That it is, in total it is more than 60.
স্যার
বাংলায় বলুন, বাংলায় বলুন।
স্যার এইখানে অনেক কমন আছে স্যার, যেমন
ওটা তো আপনাকে বলতে হবে কমন আছে যে these are the responses, not respondent. বুঝতে পারছেন? একজন নিচে লিখে দিতে হবে যে one people has given more than one responses. এটা একটা হলো ফ্রিকোয়েন্সি আর একটা হলো রেসপন্সেস। যে 30 জনের থেকে নিলাম, 30 জনের ভিতরে 10 জন, 5 জন, 30 মিলাইতে হবে। কিন্তু একজন যদি দুইটা তিনটা দেয় তাহলে you have to mention যে one respondent has given more than one responses. Then you have to clarify. Everything should be clarified in the report. We understand that part. But what is that? Complication যেটা আপনারা মেনশন করছেন ওরা তো ওদের জানার কথা না যে ডায়াবেটিসের সাথে সিগারেট খাওয়ার সম্পর্ক বা অমুক তমুক, এটা হয়তো জানতে পারে বা ওভারওয়েট, এগুলা সিম্পল জিনিস, এগুলো জানে বা জানা উচিত। আর জানলে বোঝা যাবে এটা তো আর ইংল্যান্ড আমেরিকার পিপুল না। ইংল্যান্ড আমেরিকার পিপুল কম্পিউটারে যা জানে আমি কিছু জানি না। বাংলাদেশের পিপুল আর জাপানের পিপুল, মালয়েশিয়ার পিপুলও অনেক জানে। আর পাকিস্তানি হল্লা গেলে বারে কিছু জানে না। আমি যখন মিশরে গেছি যে পাকিস্তানি মুসলিম বানানো, মালয়েশিয়ার মুসলিম ভাই গেছে আগে কিসে পছন্দ রে টুয়ান জঙ্গি আমার সামনে বলতেছে মালয়েশিয়ার মুসলিম, পাকিস্তানি মুসলিম বলতেছে মিশরে চাই, চরম অপমান করে দিল মুসলমান ভাই। দেখছেন তো? আচ্ছা, এবং মালয়েশিয়া জানে, মালয়েশিয়ার ওই গাইড আছে, আমরা 20 টাকা মিনিট কথা বলি মিশর থেকে 2000 যায়, $5 দিয়ে কেটে করে 2 মিনিটে কথা শেষ, তাড়াতাড়ি টাকা গেল। কারণ উই হ্যাভ নো মানি। আর আমাদেরকে দেখে ওরা বলতে মিশরীরা মানি, মানে আমাদের অ্যাটিটিউড মানি। এটা কিরকম অপমান। আর মিশররা তখন আমাদেরকে ভিক্ষুক মনে করত। বাংলাদেশের লোক আমার শপিং এ যাচ্ছে, ওরা আবার কি শপিং করবে? এখন মিশর কিন্তু শেষ, রুটির লাইন দিয়ে দাঁড় করায়। এশিয়ার মধ্যে এই যে 7টা দেশ না, নেপাল, ভুটান, শ্রীলঙ্কা, পাকিস্তান, ইন্ডিয়া, সবচেয়ে খারাপ দেশ ছিল কোনটা জানেন? মাথা কিছু আয় বাংলাদেশে। নেপালও একসময় আগে, আবার শ্রীলঙ্কা উপরে চলে যায়। ভারত আর পাকিস্তান তো আছেই উপরে, কিন্তু এইসব ছোটখাটো দেশ নেপাল, শ্রীলঙ্কা, ভুটান আমাদের উপরে। কোন সালে? 90, 95, 2000। আরে এরা সব উপরে। আর এখন কি? এখন ইন্ডিয়ার পরেই বাংলাদেশ, আর সব ভুলে গেছে, রসাতলে গেছে। রসাতলটা আপ ডাউন যে আমাদের যারা আজকে রাজা, কালকে প্রজা, অহংকার করার কিছু নাই। আছে কোনো অহংকার করার কিছু? এখন ব্যাপার হলো যে এই এমনি একটা বললে হবে না, ইউ হ্যাভ টু প্রুভ বাই গিভিং দ্য chi-square টেস্ট অর রেফারেন্সিং। সেকেন্ডারি লিটারেচার দিয়ে আপনি সাপোর্ট করবেন। আপনি যেহেতু chi-square টেস্ট করেন নাই যে সিগারেট খালি তার ডায়াবেটিস হবে, ইউ হ্যাভ টু প্রুভ যে আপনি 30 জনের থেকে নিয়ে আসছেন যে কয়জন সিগারেট খায়, কয়জন খায় না, তাহলে অ্যাসোসিয়েশন আর chi-square টেস্ট যে সিগারেটের সাথে ডায়াবেটিসের, তাই না? উইদাউট টেস্ট ইউ ক্যানট সে যে সিগারেট খালি এটা হয়, বা ডায়াবেটিস হলে হার্ট ড্যামেজ হয়ে গেল, কিডনি ড্যামেজ হয়ে গেল। অনেক লোক আছে প্যাকেটের পর প্যাকেট সিগারেট খায়, কিছুই হয় না। আমাদের হাসান সরোয়ার ছিল ডাইরেক্টর, একটার ইয়ার থেকে আরেকটা ধরে, এবং আমেরিকা চলে এসেছে, 2 ছেলে আমেরিকা ভালো লেখাপড়া করে। এখন তার বয়স প্রায় রিটায়ার করছে 10 সালে না 12। এখনো ফোকে, মাঝে মাঝে হয়তো একটু অসুস্থ হয়, হাসপাতালে ভর্তি হয়, আবার রিকভারি, আবার
তার মানে সিগারেট কোন ইফেক্ট করে না?
সেটা তো you have to prove the chi-square test. Without test or any association, you have to prove. Without proof, you cannot say. আমার প্রশ্ন হলো এখানে, যেটাই বলবেন আপনাকে স্ট্যাটিস্টিক্যালি প্রুভ করে বলতে হবে, হাইপোথেসিস প্রুভ করতে হবে। আদারওয়াইজ যদি হাইপোথেসিস ওগুলো সময় নেই, তাহলে আপনাকে সেকেন্ডারি যে লিটারেচার রিভিউ আছে সেটা আপনার ওখানে ডিসকাশনে দিতে হবে, রেফারেন্স সহ, অমুক অমুক এই দেখছে, তমুক তমুক এই দেখছে, আর আমি দেখতেছি এই যে আমি এই পাচ্ছি, যে আমি দেখতেছি যে আমার এই লোক যারা সিগারেট খেয়েছে তাদের ডায়াবেটিস, যারা ইয়ে আছে তাদের হার্ট ডিজিজ হয়েছে, যারা ওজন বেশি তাদের এই হয়েছে। আপনি এই ফাইন্ডিংসের সাথে সেকেন্ডারি লিটারেচারের যে রেফারেন্সের সাথে মিলাবেন যে আমার এই ফাইন্ডিংস অমুকেও বলছে, আর তমুকে এটা agreement and disagreement. Without that, you cannot build up conclusion and recommendation. In research, there is no scope to say anything from your perception. You have to, the conclusion and recommendation will be based on your findings. You have to write not only result. Most of the people just give result, no result discussion. If you go to the Australia, you will not get certificate without giving the reference discussion. আমি আমার পিএইচডি থিসিস যখন করি, আমার কনসেপ্ট পেপার প্রপোজাল পাঠাইছি অস্ট্রেলিয়ার এক্সপার্ট, বাংলাদেশে চাকরি করে ইন্টারন্যাশনাল এক্সপার্ট। ও বলছে আমার যে প্রপোজাল সে সুন্দর কমেন্টস করছে, আমার বিশ্বাস সেটা 70% কাভার করছে, সে প্রেইজ করছে, আমার স্যাটিসফ্যাকশন হলো, এটা তো বোঝা যায় নিজের অন্তর দিয়ে 70%, নট 100% বা 70 বা 70%। যখন আমি 3 বছর পরে রিপোর্ট লিখে দিলাম, তখন আবার তার পাঠাচ্ছি যে সে কমেন্টস করো, কারণ দেশের পিএইচডি তো ইউনিভার্সিটি করবে, কিন্তু আপনি যেহেতু তার সাথে আমার পরিচয়, সেটা বয়স হলো, তার কাছ থেকে নিলে তো ভালো, তার সাজেশন নেই, সে বলতেছে যে শুধু খালি টেবিল আর টেবিল, শত শত এবং রেজাল্ট ডিসকাশন। পরে আমি ডিসকাশন যখন দিলাম সেটাও ডিসকাশন দেওয়ার পরে বলতেছে কিছুই হয় না ডিসকাশন। অসগুলি ডিসকাশন দিলে হবে আপনার, অসগুলি গ্রাফ আগে দিলেই হবে। ইউ হ্যাভ টু নো হোয়াট শুড টু ডু, হোয়াট শুড নট টু ডু। এই যেগুলো দিয়েই আপনি গ্রাফ, পাই গ্রাফ আরো করতে পারবেন, কোরিলেশন রিলেশন অ্যাসেসমেন্ট করার ব্যাপার না, কিন্তু কোন জায়গায় করতে হবে, কোন জায়গায় করতে হবে না, এটাই হলো জানাটাই হলো ইয়া। এই জন্য ইন্টারন্যাশনাল এক্সপার্ট। এত কিছু বলার উদ্দেশ্য, আমাদের বার্ডে যা হচ্ছে সবই ফাউন্ডেশনের নামে কোন রকমের দায়সারা